Welcome back to the Little Spark Big Impact podcast, where we ignite the passion of pediatric providers like you. I'm your host, Mika Mitchell, here with my co-host, Joe Schreiber. As pediatric providers, we play a pivotal role in a child's development. We educate the support system that empowers caregivers, and we celebrate every victory, no matter how small. Each episode will dive into different topics and the latest research to help you make an even bigger impact with those you work with. Whether you're a seasoned professional or just starting out, this podcast will hopefully give you ideas to support the positive impact you can have on the lives of the children and caregivers that you have an opportunity to work with. Our goal is to spark deeper thinking, reflection, and learning from each episode. Today's episode, we will be discussing spinal manipulation and spinal mobilization.
And we are excited to have with us today Dr. Barb Connolly, who is going to be talking with us about spinal mobilization and spinal manipulation with our pediatric population. So, Dr. Connolly, would you please introduce yourself, tell our audience a little bit about who you are, your expertise, and how you came to bring this topic to us today?
Well, I'll make a disclaimer to begin with. I am not an expert in spinal mobilization and spinal manipulation, but I'll give you the history of how I got to this point of providing this information for you. Many years ago, and I'm not going to say how many years ago, I was one of the original founders of the pediatric section of APTA, a lowly practitioner who was just excited about pediatrics. And as a founder, I volunteered to become the secretary of the section, later became president of the section. And when I went out of my presidency as for the academy, it became evident that internationally there was not a group of physical therapists. So at that point, when I went out of my presidency and the incoming president was Sherry York, we went to the World Confederation of Physical Therapy meeting in Vancouver. We presented a petition to develop an international pediatric group, and I was fortunate enough to have it founded and become the first president of the International Organization of Physical Therapists in Pediatrics. And that was in 2007. Over the years, I served as president and then served as secretary, and now I'm treasurer. You kind of get into these situations, positions you never think that you would be in, and there you are. When I was a PT student, I said I never would go into pediatrics, and now I'm over 50 years in pediatrics. I said I never would do public speaking, and I've done that the majority of my professional life. So for the young therapist, you can get involved very early on, and your interest will take you to places you never thought possible. So where we are now, and why I'm coming to you.
I love that.
In 2020, when I was going out of my presidency and Sherry York was coming in as the president of the international group, we were approached by IFOMP. And IFOMP is the International Federation of Manipulative Physical Therapists. They just changed their name to Orthopedics and Manipulative Therapy this last year. But we were approached by IFOMP as an international pediatric group, as they were the international ortho group. There's been a number of questions over many years about the safety of manipulation and mobilization in the pediatric population. And in 2020, it came to a really highlight because in 2018, there was a video that was posted in Australia of chiropractic care, manipulation and mobilization of a 2-week-old baby, an infant, that was diagnosed with a diagnosis that is within the chiropractic world that's called the KISS syndrome. Kinetic impairment of suboccipital spine, KISS. And the treatment for KISS, even at 2 weeks of age, was spinal mobilization. And so the Australian government actually put a moratorium on the use of chiropractic care for young children. The Australian Physical Therapy Association, as a part of the World Confederation, came to our two groups and said there's not an international consensus. There's not a statement about the use of spinal mobilization and manipulation. And we would like for your two groups that represent international physical therapists to develop statements. So that started in 2020. So at that point, there were representatives from IFOP, two of which were from the APTA, Ken Olson, who at that time was president of the American Orthopedic Group, and a statistician from Texas Tech. And then there was one representative from the PEDS organization from the US and one from Australia, since Australia was the primary push mover in terms of our group. So there was a group that was set up to begin to investigate. Now, it was not just that group. And as we go through today, this afternoon, I'm going to go through the steps that we went through. We wanted to make sure when we began to look at the effects of mobilization and manipulation, we wanted to make sure that we were looking from a global view, not just from one or two countries, but we were bringing in experts from a number of countries. And we wanted to make sure that we looked at what was available in the literature. And then if we go to the first slide, there, as we went through this process, we wanted to make sure that we were looking at all the literature. We were looking at evidence-based practices. We were looking at expert opinion. So as we went through our process, we also had a Delphi study so that we brought in experts, not just looking at the literature, but what did the experts say? So I want to walk through the process before I get to any of the statements that we came up with. And I know you may have some questions as we go along, but I want to make it very clear that going into this, we felt that we needed to be very open to all the literature, to examine it in a very systematic way, and then to bring in people that actually used manipulation and mobilization in terms of that Delphi study that was done. So I don't know how easy it is for everyone to see when they look back at these slides. So if you look at it, it was a 4-part stage. It says 3, but there were actually 4 steps that were done. So the first was a systematic review. So let me talk a little bit about the systematic review. I think it's very interesting in that in the systematic review in that stage 1 or the literature review stage. The task force looked at the literature. They found over 3,800 articles. And the research that was done, they looked at literature that came from the PT world, that came from the physician world, MDs. They looked at the chiropractic literature, and they looked at the osteopathic literature because they wanted to make sure that they were looking at what was done, what kinds of interventions were done during manipulation and mobilization. They wanted to look at what kinds of diagnoses were included in the practice of using manipulation and mobilization. They wanted to look at what kinds of adverse effects might have occurred versus benefits as they looked at the literature. And in this systematic review of literature, they took the 3,800 plus articles and actually had to narrow it to 87. Out of all the literature that was there, only 87 included the information that was needed for this systematic review.
Can we just take a pause there and appreciate the researchers because of the due diligence that they had to do to refine that number, a massive number, right? And so to this process, I think it's so important for us to appreciate these types of systematic reviews that really do refine so like a mass volume of evidence, and sometimes wanting to be an evidence-informed practitioner seems daunting or impossible, because like, how can I possibly go through everything? Well, guess
Yeah.
what? When you find articles that have done that, that refinement for you, it helps it to be manageable. So I do appreciate that, and you sharing how that has, that process of narrowing it down, from a pretty exhaustive search.
From a very exhaustive,
Yeah.
and they actually, the researchers, and they were a part of this group, and that's why we had researchers, we had statisticians, we had certainly people that were used to doing systematic review. Australia, I have to applaud them. They are exceptional in terms of doing systematic reviews and following the international guidelines. And so they really led the group in terms of how are we going to narrow this down? What are we looking for? And so it did, as you can imagine, it took a while to get that systematic review done. And it was published. Everyone can access that systematic review that was done. It was published in the BMC Pediatrics in 2022. It'd be really easy to get it as a reference. And the main author is Mickey Milne, M-I-L-N-E.
Yeah, we can share
We can share some of those references. And Nikki is at Bond University, one of our representatives, and she and her group really spearheaded that. So they
can I jump into just to sort of reiterate what Mika had mentioned. I think the other thing about these is that they're very transparent. We all have biases. So when you go and look for literature or research articles, you might find one or two, and maybe you don't sort of like the title or the abstract, or it's not agreeing. And so if you look a little bit further, you might find something that maybe so the transparency, the fact that they share their methods, their sort of rigor, and how they're selecting articles, that they're searching all the literature, not just the PT literature, because maybe our bias as physical therapists might be, well, of course this doesn't work, or this is a bad idea. When you mentioned about that 2-week-old, personally, I sort of probably made a facial expression there. You sort of cringe a little bit. Well, that's my bias, so I would suggest that, in order to be fair, that we have to be very transparent and look at all the literature and be willing to have our minds changed if that evidence emerges in that search that suggests that does work or doesn't work. So just to sort of reinforce Mika's point there about being grateful for these individuals willing to put in this work to do this in a transparent way, in a comprehensive way, is just it's just tremendous. And for a really important question, right, that we sort of need to know the answer to clinically.
And that's what we wanted in terms of being unbiased. Now, we did have certainly people on the group that did the systematic review had their own personal opinions, and we had some that said, I can see it might be appropriate, maybe not for a 2-week-old, but I can see it could be used with a child that's 15 months old. The ones that said that, however, typically were not the pediatric, meaning the young age children. They were more PTs that might use chiropractic mobilization and manipulation in an adolescent population. So the bias comes in not only in terms of what is your area of expertise, physiotherapy versus some other physician, osteopaths, chiropractors. It also depends on what age group you work with within your own profession as to what your bias might be. And sometimes it's exposure. You haven't had that exposure. Other times it's you've been successful in your practice, but it might not have been for a child that we really were looking at in terms of getting all of this information. And the information, even though we say from the root, meaning from when some of the words were first seen in the literature, mobilization, manipulation, or something that would be similar. Even though it was from very early on, there wasn't a lot of literature early on, and there's still not a lot of literature. If we see that in order to have that good control of how effective, because certainly what we wanted to see was to pick up on what is the effectiveness. That was certainly one of the major reasons of this review. The second was to see how are people measuring outcomes. If you say it was effective, what is your measure of effectiveness? And so that was also one of the purposes of this first systematic review. A third purpose was to see if there were guidelines that were available in different countries or regions or organizations related. So it was a very comprehensive, systematic look at these articles. And the one thing that after the systematic review and in the article that was published was the fact that we need additional systematic reviews of different aspects of the practice related to mobilization and manipulation that were well controlled. So that was the first systematic review. And it was published in 2022, and that was the first step. Now, the second step was a scoping review, and the scoping review is our step 2 there. And in the scoping review, what the team did was to look at what kinds of assessment tools were used. So from the literature, that original systematic review, they were able to identify what was used to look for success or efficiency. So from those reviews, they pulled out patient reports, how patients reported. In this case, it could be the family or the child if they were an older child, clinician reports of success, observer reports, and then the last was performance-based effectiveness. So 4 different aspects of outcomes were scoped as to what did they find, how effective was it in measuring, and they used an international scale for effectiveness. You know, how was it sufficient, insufficient, inconsistent, or in some cases not even reported, other than just saying we think they got better. You know, in some of the articles that they reviewed, there was no measure of outcome. So the group in the scoping were able to find that there were very few measures of outcome that were sufficient. For us as pediatric therapists, one that had the greatest efficiency or greatest psychometric property was the Alberta Infant Motor Scale in terms of measuring the outcome for some of these studies. I thought that was important for us to know. The other that was effective was the pediatric assessment quality of life. Those 2 scales, ones that we use in all of the review, were found to be the most reliable and sufficient in terms of measuring outcomes.
I feel like this is a plug for that use of our outcome measures and that language too. You know, how often do we use the language of how effective it is, right? In that, what lines up with research to keep it going and to make it relatable. So I think those are some important things to consider, and confidence. And yes, I currently, I teach pediatric physical therapy, and I'm like, yes, my students know how to do the aims, and we've practiced that. And now, you know, I can add that to the next time we talk about it is, you know what, this has been shown to be effective for different things depending on what you're looking for.
So I want to just take a step back and talk about from that systematic review and how it related to the scoping review as well. Because we think of the mobilization and manipulation primarily being related to spinal mobility, alignment, but some of in the systematic review, they said that, and this is where I'm going to give you the whole list and make sure I don't leave the list out of what we were looking at. This early study said that if there was a malalignment of the spine, that could lead to problems with infant colic, breastfeeding. There could be problems with attention. There could be problems with certainly torticollis, plagioencephaly. But there also in the literature talked about mobilization and manipulation being used to treat asthma, being used to treat headaches, being used to treat children on the spectrum. So in that review of the literature, they didn't look, and cerebral palsy, you can't leave that one out. So they did not look just at children that had spinal malalignment in the review of the literature. They looked at the use of manipulation and or mobilization in those other diagnoses as well.
We appreciate that diligence.
So in the scoping, when they looked at the types of measurement tools that were used, they also looked at tools that measured changes in asthma, that looked at hyperactivity scales, that looked at scales that would relate to colic, breastfeeding difficulties in infants. So there were a lot of measurement tools. So probably, if I go back and count them all, there probably were over 20 assessment tools. And the Alberta and the Pediatric Quality of Life were the only two that had strong evidence of good measurements of outcome that were not subjective. So
another plug for find an outcome measure for what you want to test. And that's cool.
Yeah, and I'm gonna just like, when you think about what happens with mobilization or manipulation, the change is more at the impairment level, you would think, and then somehow maybe that translates, or that's what the argument is, that translates. But it sounds like, Barb, there wasn't, I don't know how you would measure if something different is happening, at that spinal juncture, or whatever the focus is of the mobilization or manipulation. I don't know how you would sort of measure that. The only thing that maybe comes to mind is some sort of more movement or motion in a particular direction that you see before and after. But to me, that sort of strikes as a problem just in general with this, research wise, but certainly like clinical practice and justifying it is really like moving here makes asthma better. So
certainly. And what we were looking at was improvement. If you say that mobilization, that manipulation improves, how are you measuring?
Absolutely.
Is it purely subjective on the part of the parent or the saying they're better?
Right.
And we do know that sometimes the effect of any treatment, the parent perceives that they're better. It happens, that happens. So in looking at that systematic review, I said that they looked at adverse effects. They wanted to know what kinds of adverse effects. And this also feeds into why did we want to see what's effective in measuring the good. You want to look at the benefit versus the harm, adverse effects in terms of any intervention that you make. And what came out in the systematic review was that there were some very direct adverse effects. There was a study, and I'm going to cite one study that really sticks out. There was a cohort study of 199 infants that were seen in physical therapy, and this was from the Netherlands. These children, infants, did get mobilization, manipulation. It was hard to see exactly how big the thrust was, which would take us into the manipulation rather than the mobilization. But they found in this study that these infants, in 59% of the infants, they experienced a vegetative state at the time of the mobilization manipulation. And this vegetative state meant that they experienced either apnea, profuse sweating, flushing, or bradycardia. That was in 54%. 54%. And there was one fatal case that was reported of an infant who received upper cervical manipulation and had the reflex apnea, sweating, and then had a massive and fatal brain swelling afterwards.
Wow.
So when we look at, certainly when you look at the effectiveness of an intervention, you have to look at the direct adverse versus the benefits. The research in terms of the systematic review also talked about the indirect adverse effects. And the adverse effects were missed serious diagnosis that was causing that limitation of movement in that cervical spine. Certainly missed that maybe this child had CP, had a fractured clavicle, brachial plexus injury. There were a number of missed serious diagnoses that were seen in some of these studies. And for us, as pediatric physical therapists, probably the one that we would like to focus on is that there may be delayed evidence-based interventions if only mobilization and manipulation was done. And I told the two of you that I would tell you a story, and I'm going to tell the story here.
Story time.
I know, and I love to tell this story because probably that's why I'm really interested in getting the finding of this study. A number of years ago, when I was involved in I ran a clinic in a very rural area of Northwest Tennessee. There were not a lot of pediatric therapists that were there. I was there once a month, and I saw the infants in the program. And sometimes it was up to 35, 40 infants I would see in a 2-day period of time. Early days of early intervention. But I relied a lot on parents and parents working and playing with their children in early intervention. And I had one parent who didn't enter until her daughter was 18 months old. And this daughter, with 18 months, had athetoid type CP. Hypermobility, a lot of hypermobility. And so I was working with this child, and the mother had a lot of pressure from her family members who went and had their monthly manipulations done. And so the mother said, Barb, my family thinks that I need to have my child receive chiropractic care as well. And, what do you say? At that point, we didn't have a lot in the literature. We didn't have a lot in the literature about what were the adverse effects. I didn't have all this information, definitely. And I said to the mom, my goal for your child is to get more stability. More stability. The goal of the chiropractic physician that you're seeing is more mobility. I want stability. I said, we can't both see her because we're working against each other. I am trying to get that stability. He's trying to get, or she's trying to get. You need to make a choice. And she said, I want both. And I said, it won't work. We're working against each other. I said, this is your child. This is your child. You make the decision. This isn't my child. I certainly am concerned about your child, but this is not my child. This is your child. She chose chiropractic. But I didn't alienate her because I said, if you ever want to come back, please let me know. We'll get your child scheduled. She was back within 3 months. The child lost the head control that we had gained. And she felt very bad about it. I did not blame the mother. It was her decision. And because I needed to say, it's your decision.
Right.
But at that point, if I had had the information that we now have, the international statements of which the US APTA was very involved with, then I could have shared with this mom what we knew.
Absolutely.
Again, it's still her choice. It is still her choice.
Right. I
But
think that's important. And thank you for sharing that story, because sometimes we want to make that choice for others, or others want us to make that choice, and, empowering them with the information. And what you had at that moment was knowing what it is that we do and knowing what the goals of the other interventions are, and being able to express that and give people space to make that decision. And I love how you kept the door open. Like, don't, you can always come back, and
no,
knowing, she understood what you wanted for them too. So I think that's something that could be helpful for providers. But now we have this evidence. So there's that.
we have it, Mika. But I also, it's still going to be important of how do you share this information with the family, so that they do feel welcome to come back
Absolutely.
at some point. And you hope they will.
Yeah, for sure.
You hope that they will. And I'm not saying that will always happen, that outcome might not be there. But our goal should be to provide the best intervention that we know and to share that information. So I'm not going to spend a lot of time on it. But I think the question that I got many years ago is still a question that therapists get now. What do you think? What would you do?
Yeah, Barb, I'm going to jump in because I mentioned earlier before we started, the journal club, some of the conversations that I've had about this article, and just what you mentioned is that it comes up, how should I handle, or if a child and a parent is sort of adamant about it. I wonder, given the evidence, because the choice that, or your response is we sort of can't both continue. You kind of have to pick. Would that still be the same like today, given the evidence? Would you be a little more stringent with that? Because the response a lot of the therapists that I've talked with about this are, well, that's great, or good luck. We'll continue to sort of they continue to see the child even though they're also going to the chiropractor. So I wonder if you might have a different approach, or what you think about that.
Well, I think it depends on the parent and the parent's understanding. I had parents that I worked with that had 6th grade education. I had parents that had doctoral degrees. We were at a university setting. We had a lot of the physicians and the pharmacist and some nursing program was there. Those individuals who had children, I could feel like I could be much stronger in terms of saying, this is the evidence, and these are the adverse effects, and be more in depth. For parents that aren't familiar with medical diagnoses, that aren't familiar with these adverse effects, I might be a little bit more gentle in how I explain it. But here's the other fact, and we're going to get to this in just a minute. When they looked at all of these different diagnoses, then they came up with, researchers came up with charts that said for this diagnosis, definitely there's no evidence of effectiveness. With this diagnosis, there's an increased evidence of adverse effects. So again, it depends on the diagnosis of the child as well. So I could spend hours on this, but I know we don't have time. So
no, this is great. But thank you. And take us through this journey.
Take a next step. Well, after the scoping review was done, we went to the Delphi, number 3 stage. And in the Delphi stage, we had 3 rounds of looking how we use their expert knowledge. And there were 3 rounds. There were 26 PT experts representing 8 different countries. So it was not, again, localized to one area of the world. We tried to get all the regions of the world involved, as well as experts. So the first round, in the first round of the Delphi study, it was demographic information about the participants, their area of expertise, and we got those that saw young children, infants, young children, and adolescents. And then we had open-ended questions, just asking them what kinds of conditions or impairments would lead them to do either mobilization or manipulation or not recommend it. And then what barriers were there in terms of providing mobilization and manipulation. So it was just kind of open-ended. The second round was looking at a 4-point Likert scale, 1 to 4, about by age, spinal level, and technique, which conditions would be appropriate, which ones would be inappropriate. And then also looking at age and spinal level and whether they used manipulation and mobilization. And then the third round was analyzing all of those inputs and looking to see where were there holes in terms of the literature, the information. So not just one part to the Delphi. They did 3 rounds, and it took them to the 4th step, which was analyzing all of the information that came in from the systematic review, from the scoping, from the Delphi, and then coming up with the statements that were developed.
I feel like that gives us so much more confidence. Like the more you hear about how the process goes and the just what is involved in it, like it gives you confidence in trusting the results, right? Like where we'll get to at these consensus statements.
And that's what we wanted to make sure of. As IFOMP and the International PEDS group, we wanted to make sure that those questions that would come up about the validity of how did we develop these statements, and to make sure that everyone realized it was not something that was lightly undertaken, that it was very serious in terms of if we're going to do this as an international statement that then to send out to our member organizations. The World Confederation of Physical Therapy now has changed its name to World Physiotherapy. So it's WPT rather than WCPT, which a number of us knew that group. And we represent over 160 countries. So when any group within the WPT comes up with a statement, we have to see how it's going to affect many different countries from all regions of the world. So I'm talking about it from the US point of view, but we took all those points of views into consideration. So if you'll go, I think it's the next slide that you have there, Mika. That, okay, and if you'll blow that up just a little bit. So if we look at that, and I'm going to kind of read this, make sure that you get all of the top is the level of evidence statement. And I'm pointing to it on my screen, I'm sorry. But at the very top, it says level of evidence statement from the scoping review, from the systematic review. And so that first column under level of evidence says, what does the systematic review say? And the second column looks at high quality reviews. The third is from the scoping. And then the fourth column is under adverse effects. I know this is very busy. It's very busy. These are in one of the publications that was made in terms of the policy statements. It was just published in May of 2024, and it has all of these detailed graphs for all of the different diagnoses. And on the side of this one, it says torticollis. So this was what was found in terms of the systematic review, the scoping, the Delphi study, as related to torticollis. So these kinds of graphics were developed for scoliosis, for torticollis, for autism, for upper cervical pain, for headache, for every one of the diagnoses that were included in the review, this kind of graphic. And you can see that the red circles means definitely not. The yellow circles mean maybe you might use this, and green would say yes. So if you look at the bottom part of this slide, and so it's got on there the impairment, the age, the region, so C, cervical, T, thoracic, L, lumbar, and then other measures that decreased motor control, decreased proprioceptive awareness, joint hypermobility, joint pain, so some other types of impairments that you might see with torticollis. They've identified when would you use mobilization, and that's the first set of circles there, and then manipulation would be the second set.
So there's one of these charts for then those different
Every single one of them.
So it takes all the words that someone would say. Now there's this visual, which I find to be very helpful, and I appreciate the orientation. We'll try to do a job at highlighting these different areas when our viewers consume this information. But this is wonderful.
And like I say, these are published. They are available in the article that was just published in May 2024 with all of the policy statements. Okay. When all of this was being developed, this information was also presented before we came up with these charts, or presented at international meetings. The first time it was presented at WPT was in Dubai in 2023, and there was input at that point to the group about their findings, their initial findings. This was also presented at the combined section meeting by Ken Olson last February, and the proceedings from that, you can get that as well. So as we went along, everything was presented internationally as well. So people didn't have to just read, they could go to the meetings. The final document was presented in this past fall in Geneva. And it was at the IFOMP meeting to the group. And it was very interesting, their input, because here at IFOMP, you had practitioners who worked with adults as well as adolescents and some with infants, and young children, but not all. So we gathered those informations. And Joe, as you said, as you had your journal club, those kinds of questions that you had, we also had as we did the international. We do have some individuals internationally who are very upset with these statements, because in their mind, in their country, mobilization is done. But unfortunately, that literature isn't saying where's the benefit. Again, it's personal opinion, personal bias, and we try to stay out of that bias. And I think that's an important piece, very important piece.
Let the data lead.
Let the data lead. And for us, it's being informed of the data. You don't have to be a part of actually doing the research, but knowing what's there and what does help you. And I'm saying the same thing that we said all along, but a part of this the podcast today is to let you know it's there and you can get it. You can read all about this. And I hope I've sparked some interest in some people that want to go and look at some of those. All of them are available. So let's talk then about what actually did all of this lead to. Well, it led to the policy statements. And these are, we have a number of them. These are the consensus statements that came out of that whole long process. The consensus statements are also published in that May 2024 article. But the first is, spinal manipulation mobilization should not be performed on infants. There was not enough benefit, and there were too many adverse effects for the group to say, yes, maybe you should do it. Use your clinical judgment. It was no, it should not be performed on infants. Cervical and lumbar spine manipulation should not be performed on children. That was another statement, because when they looked at the cervical and the lumbar specifically, should not be performed on children. Now, infants, in the terminology here, infants is 2 years or less. Children are 2 to 12 years, well, 2 up to age 13, 2 to 12.
It's important to make sure that people are aware of like those distinctions, right?
That's right. The infants is not less than 6 months. They're talking about up to 2 years of age should not be used. Okay. So the cervical and lumbar spine manipulation should not be performed on children. They had more adverse effects if it was done cervical or lumbar, not as many adverse effects as on the thoracic area. Okay, if you go back and you look at those charts that we have, there's a yellow for the thoracic saying, yeah, maybe it's okay. All right. Okay, the next
more
slide.
stable there.
Yeah, the next table. Okay, so here is the spinal, and there we go, thank you. Spinal manipulation and mobilization are not appropriate and should not be performed to treat non-musculoskeletal conditions. Okay, so here are the conditions that were looked at. The asthma, attention deficit, ADHD, autism spectrum, breastfeeding difficulties, cerebral palsy, infantile colic, nocturnal enuresis, and I didn't even talk about that, but that was one of the ones that they looked at, and otitis media, because these are diagnoses that mobilization and manipulation have been used for in the pediatric population. Okay. The fourth consensus statement, manipulation and mobilization may be appropriate to teach adolescents. So here's our 13 and up with musculoskeletal conditions, including spinal mobility impairments associated with neck and back pain and neck pain with headaches. Now, let me tell you, a number of the articles that were reviewed looked at problems with children that participate in sports or sports-related injuries or sports-related pain. So certainly scoliosis might also be involved there, but here they were looking, a lot of the literature in treatment of adolescents were more in terms of headaches and back problems associated with sports. One of the persons from the IOPTP on the group, her area of practice was really sports, pediatrics and sports. And she was doing a number of manipulations and some mobilization. She was okay with that. I mean, had a lot of background in it. And she was surprised by some of the outcomes that they found in the systematic review and in the scoping reviews. She said her eyes were opened a lot because what she felt was from her own practice, not what was seen by a larger number of therapists. So when we look at that, and go to the next one, and then I'll make a comment about all of these consensus. If you'll go to the next slide, Mika.
Yeah, this was the next one. We didn't read this one.
Oh, I'm sorry.
No, you're fine. You're fine.
It looked like the same color. I think it was the same color. Okay, spinal mobilization may be appropriate to treat children with musculoskeletal conditions associated with neck, back pain and neck pain with headaches. May be appropriate. Okay, so again, using your clinical judgment. Thoracic spine manipulation may be appropriate to treat children with musculoskeletal conditions, including spinal mobility impairments associated with neck and back pain. So, okay, not just the spinal mobilization, but the thoracic spine. And then the last one, no evidence of high certainty is available to recommend spinal manipulation or mobilization for pediatric populations. So when they looked at the level of evidence, they looked at the different levels, and nothing came to the level of high certainty. So this was the last one that came out. Okay, so those were the statements. Now to make it easier to distribute it, to practitioners, we came up with infographics. And I know everybody loves infographics because it pulls everything really together.
Yes.
So,
I will speak for the everyone's that love it. Thank you again.
well, we're visual learners. We like things that visually we can see. So here's our position statement. These infographics are available for downloading at the IOPTP website, and it
We'll
is
share that. We'll share those links as well.
That website is very easy, I think, to remember. It's www.ioptp.org. So we'll get that out to everyone so that they can look at that website. Couple of points that I find people aren't always aware of, and that is, if you are a member of the Academy of Pediatric Physical Therapy, you are a member of the IOPTP. You are automatically a member.
Can you say that again?
Yes,
this is like, sometimes we look for, what is the member benefit? This is a benefit. Did you know you're in multiple organizations? I have access, right?
Yes. The Academy pays dues to the IOPTP each year in order to have their members be a part of the IOPTP. You, as a physical therapist, cannot join individually. You are automatically a member if you're a part of the Academy. And I would say the dues are not extremely high. The Academy pays $1 per person per year, $1.
Okay.
And that is the only income to the IOPTP as we develop these statements, international statements, and we have a number of them. And I have to applaud the Academy for all of the CPGs that have been developed, because the IOPTP really uses that a lot as we develop the international statements. The Academy is a leader, and we know that. But it's really, I don't think we say it enough that if you're a member of the Academy, you're a member of the IOPTP. You can go to our website. You can download anything that we have. We have free webinars for members. Now, I'm not saying they don't sometimes occur at 3 a.m. in the morning, because when we do our webinars, we are reaching people across the world. So it depends on where the presenters are. But then we put it on YouTube and everyone can see it. So this can be downloaded. And again, it goes back to how many individuals is in infancy, the top there, have had adverse effects. I cited a study that had more than 1 in 4, but in the conglomerate, 1 in 4. And so red means no mobilization, no manipulation with infants. In the yellow, some types of interventions that would be appropriate. And then at the bottom, where we're looking at the adolescent, a lot is based on clinical judgment. Okay, so the next infographic.
Yes.
There we go. All right, so these are statements that we developed, that you can also download them from the website, the IOPTP website, and have them in your clinical site. Give them to your friends. Have them for meetings, chapter meetings. But it talks about the statements, and our logos for IFOMP and for IOPTP are in the lower left-hand corner, right-hand corner there. But these are the statements in very simple terms.
They look shareable for social media,
and they are shareable.
Yeah, so this is cool.
Yes, you can download those directly. This is put into a PowerPoint. They're individual, so they're not clustered like this. Infants, toddlers, adolescents. Okay, and then the last one. Is that the last one you have, Mika? One more. Okay, so this talks about is not appropriate and should not be performed to treat non-musculoskeletal conditions. Again, that goes back to that list of conditions, and some of those are up at the top. So that's the information.
I'm just going to chime in. Like this was so helpful to hear. I've read the articles and looked at some of this, but to hear the process really reaffirms, how, as Mika said, how confident we are in these recommendations. And the whole idea of disseminating, of course, the podcast here and publishing the articles and all that stuff is an effort at that. People that are listening, I think you're now charged with sharing this information with your colleagues, maybe putting these infographics on bulletin boards in your waiting room.
Yes.
And when parents bring this up and ask your opinion, that you are confident in sharing what the recommendations are of this international expert group. So it's now the sort of ball has been tossed to all of us, or handed off, or however you want to say it, that we need to get the word out on this, because we're all charged with providing the best care we can for kids and families, infants and families. And so that's based on the evidence, and therefore, this is an obligation for us, not sort of nice to know or something. It's an obligation to get this information out. This is a state of the knowledge as of, today in 2025. And we're obligated to get that out and make sure it's influencing all of our practice and clinical decision-making.
This is definitely a conversation starter.
Definitely. Yeah. And, we talk about knowledge translation. This is knowledge translation. Again, evidence informed, so that we have it. And the individual practitioner should not feel that they're putting themselves at risk for sharing this, because it didn't come directly from them. It came from an international group. In the US, we have not gotten to the point of banning it for infants, which Australia has. Certainly, I don't know if that would ever occur, but it's important to understand.
The recommendation is at least what we can stand on right now. And I think, I appreciate in everything that you shared, and the process that happened for these statements to be made with confidence, is that whenever we're looking at the research or we're making recommendations, that people do, sometimes we get focused on what is the benefit, but we really do have to look at what is the adverse, and that's kind of what drives this, is that it could be really bad. And that's a risk where, because of the adverse effects, like, let me make sure that you truly understand what it is you're getting yourself into as you make this decision as a provider to share or not share, or to a family to decide if this is what they want to do. So do you have a last statement, Barb, to encourage if I feel like you sold it already, but like, just as a pediatric provider with your years of experience and confidence, and just seeing how research has changed, what last statement would you like to share to encourage this next generation? We're all about a spark. A spark can, clearly a spark, one conversation, one idea, one concern brought then this beautiful thing forward. So please, what would you share to us?
Yeah. So for the younger therapist, I would say just being involved with more experienced therapists who can tell you about their mistakes along the way makes, it says we're not all perfect, and we're all continuing to learn. I've been in the field for 55 years now, and I still take courses. I still go and learn, because we continue to expand our knowledge. And so just stay involved and don't get in your little cocoon and be open to the research that comes forward. So
thank you so much. Joe, do you have any last words?
I don't have much to add. It's pretty wise words there, and hopefully inspires all of us, like that whole aspect of professionalism, continuing to learn and being willing to integrate the new research and new evidence into your thought process is just essential. So.
Absolutely.
Thank you so much. Hopefully.
Well, thank you for having me.
Yes, thank
get the
you.
word out. So thank you for giving me the opportunity to do that.
Anytime you want to come and share. We appreciate you and everything you do. And we hope that this has sparked more conversations in the future.